Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I am your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts, hear stories from the emergency department, and listen to people who have struggled from addiction. Friends, fentanyl is plaguing America. It has infected all illicit drugs, from cocaine to meth, counterfeit pills, and even marijuana. If you're around someone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. If you need a prescription for naloxone, you should have one. No questions asked. That is why I am offering a free prescription to anyone who needs one. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. And if you like the show, do me a favor. Give us a 5-star review and subscribe. Your stars are very much appreciated and go a long way in supporting the program. Today's episode is sponsored by Families Against Fentanyl. FAF is an organization set on breaking the status quo of failed solutions and to get to the core of the supply chain of deadly fentanyl. Learn more about FAF by visiting familiesagainstfentanyl.org and sign their petition to declare illegal fentanyl a weapon of mass destruction. Hello again, everyone. Always a joy to be with you for an innovative, high-truth conversation and solutions. Have a listen to my testimony in front of California Senate Health Committee, March 23, 2022 on SB 864, Tyler's Bill on Fentanyl Testing. Members of Senate Health, I urge you to act today to save lives, make history, and set a national standard on the tragic fentanyl crisis. Every day, I treat patients who are exposed to fentanyl. My recent shift, I treated a young man who thought he bought a Xanax pill. He was found unconscious and barely breathing in his car. He was thankfully revived with naloxone. He readily gave a urine sample and was shocked to find out that he had no Xanax in his system but did have fentanyl. The positive fentanyl test led me to give him a prescription for naloxone and refer him to the appropriate treatment. The positive test led him to throw away those fake Xanax pills and warn his friends who may have bought the same pills. Fentanyl is the number one cause of death in the United States for ages 18 to 45, more than COVID. The number of teens who overdosed on fentanyl has gone up 3-fold. The number of Black teens who overdose has gone up 5-fold. California, fentanyl's deaths have gone up 5-fold in the past 2 years. Our San Diego medical examiner is dealing with 2.5 fentanyl deaths a day. Increasingly, hospitals around California are including fentanyl as part of the standard rapid urine drug screen. This bill will push the rest of California's hospitals to do the same. A rapid urine drug panel tests for cocaine, amphetamine, and opiates such as that come from poppy plants such as heroin or morphine. The traditional drug tests do not typically include fentanyl, a synthetic drug. To include fentanyl, hospitals need to purchase a 75-cent fentanyl reagent. Hospitals quickly adapted to include COVID testing with the pandemic. They can and they should do the same for fentanyl. Fentanyl testing will not solve the crisis, but it will engage the medical community in solutions and could save some lives. I urge you all to unite in leading California and our nation in solutions on fentanyl. Please support SB 864. What do you guys think? Who is the nay votes on that bill? No one. This passed unanimously with bipartisan support. Senate Health will go now to appropriations. And with that, let's hear our question of the day.
Hi, my name is Crystal, and I am an ER nurse and a base station nurse working with paramedics. It's so great to be able to talk to you, Dr. Lev, and for you to take my question on High Truths today. I sure do miss working with you in the ER. We have been offering medication-assisted treatment for patients with opiate addiction in the emergency department. This is the MAT or MAT program. I'm wondering if there is such a program for paramedics to start addiction treatment in the field.
Crystal is an emergency nurse extraordinaire. She is the best team spirit person I've worked with ever anywhere. She managed the pandemic by bringing us all matching masks for St. Patrick's Day, Valentine's Day, 4th of July, Halloween, and I posted some of Crystal's group photos on my LinkedIn page. We have such a stressful job, and she was able to bring camaraderie and spirit to that environment. And Crystal, you have a brilliant idea. We are doing addiction treatment in hospital emergency departments. What is the role for paramedics? Let's find out from people who are doing just that, Martha Waller and Tara Tucker. Dr. Martha Waller is a Senior Program Evaluator with Chapel Hills, North Carolina. She has worked on substance use and mental health projects for NIH, SAMHSA, NIDA, NIAAA, all that alphabet soup of federal agencies. And Tara Tucker is a paramedic and mental health professional. She leads her county's opioid task force. She developed the foundation for a mobile integrated health team of community paramedics that provides training on crisis intervention teams and post-overdose response teams. You can find Martha Waller and Tara Tucker's bio on the High Truth show notes. Martha and Tara, welcome to High Truths.
Thank you.
Let's get to know a little bit about both of you and tell us how you each came to working on the issue of addiction or helping people with substance use disorder. Let's start with you, Martha. How did you come to this, your journey to working on a pre-hospital paramedic treatment for people who use drugs?
Sure. So I have my doctorate from UNC in Maternal and Child Health, and started out my career working or researching adolescence and adolescent risk behavior, mental health, sexual health, those sorts of things. And I came to PIRE, where I am now, which is the Pacific Institute for Research and Evaluation. And we happen to do a lot of evaluation research as well as other, primary research. And I was invited to be part of a project in New Mexico. I had done my master's degree in New Mexico. I loved New Mexico, and I was invited to be part of the team to evaluate their substance abuse prevention programming in the state. So I did that for many years, and part of that included opioid overdose prevention efforts that they were doing. So that sort of, got me started in terms of opioid research as well as alcohol related research. And then this opportunity, I think originally, and Tara, you can correct me if I'm wrong, it started out as a CDC opportunity. And the CDC was looking at innovative ways to address opioid overdose and prevention. And that evolved with lots of meetings into this particular NIDA funded grant. We didn't end up getting the CDC and ended up applying to NIDA and got funding to do this.
Oh, very cool. And Tara, tell us about your journey.
So actually, I started off as a recreation therapist in a locked back then psych unit. And so did mental health and substance use inpatient. From there, I went to a community mental health center on what was called an ACT team or assertive community treatment team, where we worked with people that had dual diagnosis disorder. So I worked with the same patients that I had seen in the hospital for about 12 years. So did a lot of community mental health. About 16 years into my career, I decided I was going to go to paramedic school. One of my psych PA friends was like, go do some stuff on the medical side of the house. And once I got into the EMS world, I saw the big disconnect between behavioral health, meaning mental health and substance use, and the EMS world, but the call volume was there. We saw a lot of people, they didn't always get coded as a behavioral health patient because EMS folks are trained on the medical side of the house way more. So one of the things I did in my mental health world was crisis intervention team training it was started for law enforcement, but branched that out to all first responders because, I saw that we all need to be operating off that same playbook. And then from there, went to work for, several mental health providers, then went to an EMS agency where I was told we would never use that behavioral health stuff there, and I was like, okay, good. I'll use my EMS stuff. I was doing quality management. My background is in IT too. So I enjoy the data side of things as well. And about 6 months there, the opioid crisis really hit heavy, and it was like, okay, now what can you do? And I knew, I guess, kind of like what you see, everybody operates in their own silos. So I felt it was really important to start a task force and start bringing people together, raise awareness about what we were all doing. Through that, met an addiction psychiatrist that was doing some, work with Suboxone, and she and I would brainstorm a lot in her office, right on the window, kind of brainstorming. And I said, why couldn't we deploy this in the EMS side of the house? After somebody overdoses, right now we don't treat them. We basically just reverse their overdose. And I remember that, vividly one day asking the paramedic, she was really tired of running, some of these calls. And I said, what have you done for treatment for him? She said, I gave him Narcan. And I said, no, what have you done for treatment? Because you and I know that's not treatment. So that was kind of where it really birthed out of.
Yeah, it's interesting to hear you say about the mental health aspect. It's in everything, right? It's in law enforcement, it's in EMS, it's in the hospitals. Mental health and drugs are really, it's our bread and butter for all, unfortunately, for all these parts of society. And then, Tara, you have a personal connection to the issue as well.
I do. After I've been working on this, this project and starting with developing a protocol, since everything in the EMS world has to have a protocol, had brought 2 big hospitals together, medical directors from our state EMS, and we had kind of hammer all this out. Of course, that takes some time. And then one day I discovered that my own child had been using. And since I had already built this whole network and knew the pathway that we should take with things, ended up being able to get him in treatment within less than 24 hours. And he's got about 4 years clean now. And a lot of that was through the help of Suboxone, truly life-saving for him. And, people ask me all the time, how long should somebody stay on that medication? I can tell you, I don't worry at night. I get to go to sleep, unlike some of the parents that I deal with. And for me, it's no different than if you need medication for your heart. The brain is an organ. And so he works a very productive job, has a healthy relationship, all the things that people dream of, people who use drugs, right? So
yeah. So this is your profession. You're a health professional. You do this for a living, and then you discover, what, my son is using drugs. Looking back, in order to help other parents, what were red flags? Like, if you miss this, you're a professional. How are other parents going to figure this out early?
So I was missing the signs of withdrawal, and he would just throw one at a time at me. So like, his nose would be running, and I would be like, have you taken your allergy medicine? Right. His legs were aching, but it was during flu season. And I was like, have you taken some ibuprofen? It was never like all these things together. So one of the things that we did, even with this project, was we developed a brochure for first responders to be able to hand out to family members, telling them to look for the signs and symptoms of an overdose. But after my experience, I included in there the signs and symptoms of withdrawal, because I knew the withdrawal, I knew the overdose symptoms. He wasn't overdosing in front of me, So, and
you had no other clues of, school, the
dad,
classic poor for social interactions and the classic things they teach you of like poor performance in school, or there are other red flags that they teach. Are any of those wrong? Or
he's always been consistent with his dad and I are divorced, so he could tell me that he was going to dad's house and tell dad he was coming to my house, and we didn't communicate. That was what I would say is our big area. And the night that I figured it out, that's the first thing I did. I called his dad and he said, you have to come here. We had not spoken in years, but his dad came here, and that was a big impact piece for him. He told him that when he was in treatment, he said, when it mattered, my mom and dad came together, because and I told his dad, this is life or death. You need to come here, because that's how I view it.
Right. And from the moment that you figured it out, you said you were able to get treatment so fast, again, because that's your expertise. What's your advice for other parents to be able to do that?
Well, like my pipe dream is that one day you can call 911 and get that same kind of help you can for a medical emergency for a mental health or substance use emergency, right? I mean, it's a lot about knowing the system and the context, and that's the part that's hard. Would I have known that had I not had all the years experience? No. I mean, I know that. I am fortunate too that my child did listen to me. He could have bucked on that and said, no, I'm not going. So I do give him a ton of credit. He has taken ownership of his issue. Another big piece, I think, is he has paid for his treatment and his medications, and that made him have that ownership and take that responsibility.
Wow, that's innovative.
And I mean, I think it made him have skin in the game. He's the girlfriend that he's had for 5 years has been there down this journey with him. The communication between she and I, and the support that we gave him. He'll tell you, we've basically kind of put it together like a puzzle. What were all the things that helped you with your recovery and has helped you maintain recovery for this long? Because I think it's important for people to see it's not just one piece. It's not just the medication, it's not always the same treatment provider. We've had to change treatment providers a couple of times. And that's really important with buprenorphine, because so many people either want group therapy or they want this or they want that in order to give you the medication. And you got to find the right program for everybody. It's not a one size fits all.
Right. That's classic. So that brings us to Crystal's question. Crystal is an amazing nurse that I've worked with for so many years in the emergency department. She's a base station nurse, means she works with paramedics, teaches paramedics, and she noticed that we have in our emergency department, many emergency departments now have MAT treatment that starts in the emergency department, medication-assisted treatment, starting buprenorphine people who are who have an opiate use disorder with withdrawal. And she's asking a perfect question to the two of you: is there a practical way for paramedics to provide MAT? So you guys really took that experience and made it happen. Can you tell us about that?
So really, we kind of used the concept with community paramedics because it was a smaller group of people to teach this concept to. And when we put all our heads together, we developed the idea as a bridge. So the bridge, the hard part, we know, even if you put somebody on bupe in the ED, how do you get them to an outpatient treatment provider, right? Because that's not what usually ED physicians have time to do. So the community paramedics could be that bridge. And we found through this project, it could actually be a two-way bridge. So sometimes we've helped people get into treatment, and that treatment provider basically do their detox or short-term program and not have the resources to get them back out into the community. So the community paramedics could do that. But we started out with the initial idea that post-overdose, somebody overdosing out in the street, we could go out and offer them Suboxone. We know we're putting them in precipitated withdrawal, given Narcan, right? So we know the likelihood of them going to use to combat those withdrawal symptoms is going to be really high. So everybody wasn't receptive on day one. It usually took that building a rapport, so it took a few days is what we saw. I thought everybody would say, yes, okay, this is great, because most people on the street know what buprenorphine is, right? But we did see you had to build that rapport. It took a few days. And then people, had thoughts like...
Wait, so the pushback was the paramedics, or was the pushback the patients?
The patients. Mm. So, I think just for them to understand, hey, wait, somebody cares enough to offer me medication. This is not, that's not the norm, right? That somebody's going to be helpful, not especially somebody in a uniform, because they associate all of us together with EMS, law enforcement, that we all work together. But the idea was we would go out and give them the buprenorphine daily for up to 7 days. Once COVID hit, we saw it was taking longer to get people into treatment providers. So the state EMS medical director said you can do it as long as you need to get them into treatment. But we've seen that bridge be a two-way bridge. So daily people would go out, a paramedic would go out, do the CAL scale. So we had to teach, paramedics that.
Well, actually, take us back a bit.
Sure.
Who gets this treatment? Is it someone 911 overdose, someone who comes into the hospital, or it's only clients who before they come to the hospital? Tell me who comes into your program.
So it can be somebody that is post-overdose. It can be somebody that's in withdrawal but has heard about the program and decides they want to get started. We didn't want to make people just have to overdose to be able to get started, with a medication-assisted treatment. That didn't make a lot of sense.
But does it start with a 911 call?
It doesn't have to. It doesn't have to. So initially that was how it would work, right? That somebody overdosed, there's a 911 call, the paramedics go out, the truck paramedics would go out, reverse them if they have not already been reversed. And then ideally, and Tara, jump in, sorry. Ideally there's both a community paramedic and a peer there that will come to the scene as well and assess whether this person, number one, needs to either be transported to the hospital or would qualify for receiving buprenorphine at that time. And so there's a whole protocol that they go through to screen to make sure that this is appropriate. And if they meet that, then they are offered the buprenorphine on the scene right there. As Tara said, once the word gets out, and other folks know about the community paramedics, the community paramedics will receive phone calls from people who are in withdrawal who say, could I, yeah. So it doesn't necessarily have to be an overdose, but that's originally how it was intended. And as Tara mentioned, our assumption was that people would say, yes, please let me have the buprenorphine. And we just assumed that was a given, that they would be, they'd have just overdosed, they had just been reversed. They would be like, oh, of course, this is what I want. And that was not quite as
I'm not surprised because a lot of people who I treat who overdose, who were almost dead and even admitted to, my most extreme is had a guy who was an IV Narcan drip because he kept overdosing and whatever, it wasn't enough. So he was on a continuous infusion and he, like, when he was up, he's like trying to leave with his IV and it's like, this stuff is keeping you alive.
Please don't go yet.
Right there. There's a denial, right? Because people think they're high and being dead is a close, similar sensation.
Right. And that is exactly right. We had a lot of folks say, I don't have a problem. I don't need this. I wasn't overdosing, so there is definitely, those are comments that we certainly hear from patients. So I'll stop there.
Having the community paramedics be able to give that medication, one, was somebody that can monitor that patient, but two, it was somebody that could bridge them to an ongoing MAT program and try to find the right MAT program, since you and I know they're different programs with different requirements.
All right, so let's take us through this now. We got a 911 call, someone's overdosed, they got naloxone, now they're in withdrawal, they're healthy enough not to need to go in the hospital, which cuts that pool, because I think the most people actually need to go in the hospital, that they develop some sort of ARDS and actually need to observe them for a while. But let's say you found the people who are in withdrawal, who don't need the hospital, and that person agreed they're going to get, they want something. So now what? So
then they would be administered the COW score to see where they're at in the realm.
And then we'll explain what the COW score is.
Okay.
COW's like moo, like the cow, and it's tell us what it is.
The clinical opioid withdrawal scale.
Okay. So there's a scale, and that COW score tells us, it's very, a list of symptoms. And if you have a COW score of, what is it? Is it 8 that you use?
Martha, do you remember the exact?
I don't remember.
Okay, we use 8. We use a COW score of 8. If your COW score is 8 or more, and I know different places may be different, but we use 8. Then you qualify to start buprenorphine. If you're not in withdrawal, giving buprenorphine could put you in withdrawal, and then you'll hate it and you'll never want to use it again. So we want you in withdrawal before we start this medication. So now the COW score is done, and it's more than 8 or whatever your cutoff is.
Yeah, and typically we found that was around 45 minutes to an hour after they had received Narcan from us on scene.
So this is a special paramedic, right? Because most paramedics want to, move on to the next scene. They don't have time to play around for 45 minutes.
So that's why we use what we call here community paramedics. So they are specially trained paramedics. They get additional training in post-overdose response team. They get additional training in crisis intervention team training on really how to work with this population, understanding addiction better.
So the fire truck is now gone, right? The fire truck moved on, and now there's a different guy in a car, in a little truck or whatever, who's a community paramedic. He's a specialist, and now he's one-on-one with the patient now for a longer period of time.
And as long as they feel safe, they let law enforcement leave too. So obviously that helps, when law enforcement leaves that scene. Because the standard protocol here is usually law enforcement comes on those cases as well.
So now they're sitting at the sidewalk or someone's house or wherever it is that this happened. Could it be a sidewalk?
Yeah.
Okay. And they're going to get the buprenorphine. All right. So now take us from there.
So they start explaining the program to the person to see if they're interested in or not. If they're interested, then obviously they can dose them there. If they're not interested, then they still follow up with that person, either by phone or in person. Sometimes it's hard everybody does an overdose at home, right? So sometimes it's a challenge finding people, but they tend to share their cell phone numbers more. So sometimes, and those follow-up phone calls can be by the community paramedic or by that peer support specialist, which is somebody that's in recovery themselves. So you have, so a patient who meets this criteria, so I'm kind of picturing 911, they meet the criteria, this other person comes in a different car, a peer support person comes into the scene with a different car, and so now there's two people kind of helping this individual who almost died. How long after getting naloxone do you wait for them to give the Suboxone? So that really depends on that patient and what their score was and how long it takes to talk to somebody you got to develop a rapport with people before you can even just give them medication, right? But before they even trust you, they're not used to people that care about them, especially on a 911 call. So, and just to clarify, it depends on the time of day too, if that peer's there or not. So it may just be the community paramedic, and it may be after hours when the community paramedic's not there, and they would follow up with them the next day also. So
in the ideal situation, you would have both of them there. Because these are rural communities that we're working in, there aren't enough staff to staff this 24/7, in which case then the truck paramedics explain the program to the patient, provide them a card, and then the paramedic then follows up with the patient the next day.
Okay, so they may or may not get the buprenorphine that day.
The ideal is that they should, but no.
Yeah, okay.
In reality, no.
Okay. Best case scenario, that's your goal, that you could start that day, but sometimes it takes longer. And frankly, that makes sense. You want to be in withdrawal, right? They may,
What we don't want them is to have them in such a state of withdrawal that they go out and they use again.
Right. There's a window. There's a window there, right?
Right.
Okay.
Too, that some of the programs actually ended up finding providers that could take them the same day as the overdose. And so in that case, the community paramedic didn't have to give, they would get them straight in with the MAT program. We didn't expect that, but some of the MAT providers actually started working with the community paramedics. So,
very nice.
Yeah.
Okay. And then what happens? So the peer that goes to the scene or hears about the patient, they're with that patient for a while. How long do they stay with that person?
That really just varies patient by patient.
But the goal is to get them into the clinic and then move on.
Well, and to build some rapport with them and not everybody's going to accept. So even if they don't accept, continue that relationship. Like, hey, we're still here for you. We still can. It doesn't just stop after that 911 call. That's an important piece, I think, because typical EMS is you run that 911 call and you're done.
Right. So the peer can follow up for weeks with the patient, even just by phone. And it depends on who the peer is working for. And that's sort of another caveat of, for example, in one community, the peer is hired by the EMS. In another, the peer is hired by the MAT provider. So in that case, the peer is there available from the MAT provider and sort of checking in on things versus the EMS, which is a little different. So there's different models.
Interesting. All right. So we got this program. Now let's talk about results, like good and bad results of what, because nothing's perfect. That's just life. That's how we learn. We learn from each other. If everything was perfect, or if you pretended everything was perfect, we'd all be copying each other's mistakes, right?
Right.
My mentor is the father of emergency medicine, Dr. Peter Rosen, and he said you need to learn from other people's F-ups. Or he actually had a lot of journals, and he said we need to have a journal of negative results. And that makes sense. So why do we want to keep copying other people's mistakes? We want to be better. So, and we only publish the good stuff. So I want to hear about this program. Like what I want to hear about successes and failures. So how many people have you found and that actually you were able to enroll?
Well, so that's an excellent question. And I will say that, so this has been implemented in 2 different counties from 2 different funding streams. And one was a NIDA funded R21. The other was funded by Blue Cross Blue Shield of North Carolina. And the county that the Blue Cross Blue Shield funded, how do we put this, Tara? We rarely have very little data from them. Very engaged, very excited about the project, but getting EMS to enter data and to collect additional data that they aren't required to is very challenging. So we have very little data, even though they saw hundreds of patients and in fact worked with hundreds of patients. But we don't have data to actually say anything about it, if you can imagine.
So you're not able to say, you're disappointed. You want to know out of, 100 overdoses, at 911 overdose calls, we enrolled 10 patients and
correct.
And
Correct.
5 out of 10 of those are still in treatment 6 months later, right?
Exactly.
Right. So out of the Blue Cross, they got you nothing.
They got us only the number of calls, right? And how many they administered buprenorphine to. So that's what we have from there. And that's basically
right?
a little something. And in fact, they were very successful. Let me see if I can find those numbers for you.
Well, and I will say while she's looking for that, EMS people like anecdotal data. They do this work because, it's that feel-good profession. And the EMS documentation is not geared towards collecting behavioral health data. Like there are very few mental health or substance use related questions in the traditional documentation for EMS. So that's what I would say it was a challenge. And even though we created forms, they wouldn't always get filled out because that was an extra piece that wasn't in their computer system.
Right. We're having trouble at an even more basic level than that. So in San Diego, we created I forgot exactly what it's called, something leave behind. So you come to the overdose, we actually leave behind actual naloxone for the next time or for the people at the scene. And even that is really hard. Something as simple as that to people accept it. And I could see where that happens because you're coming in there, you're focused on the overdose, packaging the patient up, taking them back to the hospital. You don't really have time to talk, who else, and give the conversation. Can I give you naloxone? That takes a whole, like you said, rapport conversation. So I can see where even that program that we're trying to do that sounds so smart, like, hey, your chances of overdosing again is higher than anybody else in the country. We want to leave that at the scene or with the patient. That's hard to do.
Well, I had an EMT student I thought was really interesting. I had an EMT student doing ride time or clinical time this week, and they had a particular call where they administered fentanyl to a patient. And she said, do y'all not ask, like, have they ever had an addiction issue before you give a narcotic? And I said, see, y'all have been my students. That's why you think that way. That's not the traditional way of thinking in EMS,
No.
Like that should be in our simple questions that we ask, right?
Yeah, right. And mine, I go like back even, I'm thinking like trauma center. We just say, are you in pain? We give you pain medicines and ask about that later. But we do. The intervention I'm asking for people to do, if someone has cancer, you ask, does that run in your family? Someone has high blood pressure, does that run in your family? So I'm just trying the basic there. Like, you're going to ask about family history. Make it relative and relevant to the chief complaint. If the chief complaint has to do with alcohol or drugs, then ask about family history about that instead of something that's really irrelevant. But yeah, so did you find the anthem?
It's all mixed
data?
up.
All right.
For the one county, let me see if I can. I have their data are so messy, I have to say. I can tell you that
Rough number. You're
rough
you're a
numbers,
you're a
rough numbers.
scientist. You're very precise.
I know.
Yeah, this is a podcast.
So they saw about, I would say, 350 patients, 350 patients
Who overdosed?
who
911.
overdosed.
Wow. That's a
Overdosed.
lot.
And of those, there about not quite 50% had an actual community paramedic on the scene, so was able to offer buprenorphine. And then another like 60%, they were able to contact the patient by phone after that. And of those, as I recall, and I'm not seeing this in the document that I'm looking at the moment, if I recall correctly, about 30%, I think, took them up on the Suboxone.
I think that's pretty good.
So not too shabby.
Yeah, I think that's pretty good.
And yeah.
Did you run into any adverse events? So, especially with more people using fentanyl rather than heroin, buprenorphine, regular dose can be more induce withdrawal, make people feel bad. Have you run into that? Was that a problem? Have you ever had any adverse events?
I've had no reporting of anything of that sort.
Tara, you?
No, we haven't.
You haven't seen that?
We haven't run into anybody that's reported that. So
I had one patient who was in the ER for a while. I was going to get him to treatment. I actually got him a treatment bed, which is very rare. So excited about that. And I started him on buprenorphine, and I mean, I don't know that I even reported it, but he had a horrible reaction. I ended up admitting him to the telemetry floor because he became very anxious. And I don't even know if it was withdrawal or what it was, but I gave him buprenorphine, and his medical condition deteriorated. It wasn't pretty.
Oh, that's good.
Yeah. So, I mean, things like that happen. We just have to be
right
aware that it can happen.
So because they're checking in on a daily basis, hopefully they're catching that fairly quickly, but it certainly seems like that's something that is a possibility. Now, Tara, do you want to talk about the fact that the paramedic has to call the medical director to get permission? So it's not just that the paramedic is making this judgment?
Yeah, so it's not like a standing order, it's a base station communication.
Yeah, so there is a protocol that is that standing order, but there's still the communication with the physician. Again, because these emergency medicine physicians are not used to doing Suboxone.
Right, that's not their expertise. They don't know what a cow score is, right?
Exactly. Yeah,
we have to teach them.
And the one thing that we saw, looking in hindsight too, when we developed the protocol, we had the state EMS medical director there. I had my local medical director there. But then we deployed it in these two other counties. Those medical directors hadn't been involved and hadn't talked to the addiction psychiatrist. The other EMS docs were comfortable because they had sat with several different addiction psychiatrists and heard their viewpoint on these things and had the understanding. In hindsight, I think it would be good to do that with the other EMS physicians that are going to do this project, right? Is let them have some time with that addiction psychiatrist to ask their questions and understand why we support certain doses.
They tended to be very hesitant and very nervous about it, for sure. About
right. It's something new. I don't know. I'm not there.
Yeah.
And then what's the warm handoff from the scene? How often? So you said you stay with them for a week until they could get into a clinic. That means there's a paramedic going to somebody's house every day for a week, or they come, or how does that work?
However the patient wants to do it. So the patient may want to meet them somewhere or have them come to the house. But yeah.
Every day until a clinic appointment is open?
Mm-hmm.
Yes. And we found that working with the providers, though, when they knew what EMS was doing, they would actually work to get them in pretty quick until COVID hit, and that created some challenges in itself because
I think that is amazing, and I don't know how sustainable that is. Right? How can I have such a professional come to someone's house every single day to give a medication until a clinic appointment is happening, especially in COVID when I can't get our clinics are not, even we are an MAT bridge program in the emergency department to the clinic. They're asking us for 2 weeks, and sometimes patients are there again. In the emergency department, we give them like a week supply at a time. And during COVID, we were asked to give 2 weeks supply at a time. Wow, I think that's an amazing service. I don't know how sustainable or reproducible that would be for the rest of the country.
Well, and I think the key to that is you have to have multiple providers. EMS's mentality was initially, I've got one provider, we got a partner, we can go with that. And I'm like, no, it's not one size fits all. You have to have multiple MAT providers because everybody has different requirements, and some providers can see people telehealth, some can't, we're in a rural area. The telehealth piece is important, for some folks.
These are small counties, so you're absolutely right. At a large scale in a very busy metropolitan area, you're going to have a lot of staff. But that was what they were dedicated to doing. And the community paramedics in general in North Carolina are doing a lot of that outreach anyway, whether it's, to check on patients with diabetes or heart disease, so they're doing that anyway. They're out in the community, going to people's houses. And the whole idea is to keep them out of the ED if they can possibly do that.
Wow. And there's not a location. You're doing this really to fill a gap because ideally they would go to the clinic and get this done, but the clinic is not available. So you've created this other mechanism. Is that right?
Well, for here, it can take weeks to get somebody into a clinic, so that's why we basically said this could be that bridge till we could get them in.
Right.
And then once they found out they were working with community paramedics, they were more likely to get them in quicker too, which helped.
That's important. And so basically the emergency physician from the base station is writing prescriptions, to this community, that a group of people who are very, very high risk. They already overdosed, and providing medicines as a bridge before they get into clinic.
And one of the things I think is important is in our area, we don't see a lot of physicians like you writing prescriptions for youth in the ED. So taking them to the hospital wasn't helping fix the issue. They would make sure they cleared them medically and then send them back out and have to follow up. So it was a huge gap there anyway.
Huge gap. I think that, what do you think about that, having that peer in getting them incentive, encourage empathy to want this treatment? How has that been successful, or have you measured that success?
We've tried to. Again, what we have anecdotally, or at least from the qualitative data that we have from the paramedics, they feel like the peer is absolutely critical, that the peer can talk to them in a way and about their experiences in a way that, the paramedic just cannot. I think having a good peer, and a peer who is a peer who is open to MAT, because some peers, again, are not going to be open to the MAT. They're about abstinence, and you just need to, and we hear that even from the patients of, I'm not going to trade one drug for another. And it's like, well, but one drug might kill you and the other won't. So, but you'll hear that even from the overdose folks that will say, I just don't want to trade one drug for another. And if I'm going to quit, I'm going to quit cold turkey. And so having somebody who can really explain to them about why this is different, why this is not the same, and why this is so much better than going cold turkey. And, I think is really critical. But that said, I think if you have the right paramedic, probably the right paramedic could do this as well. But I think having the peer there is really wonderful. And I think from the paramedic standpoint, it feels much better that somebody else can take on some of those harder conversations.
Frankly, it's a different personality, right?
Mm-hmm.
I know that we're an emergency department, and we have a little section for just behavioral health patients. And the nursing skills for an ER nurse, go, next, versus a behavioral health nurse who's like there and patient. It's a completely different skill set, it's a different personality. And the paramedics, I'm sure, is like, okay, we're done. Like, okay, we got the brief for normal, let's go, next move, right? Versus a peer support, it's a different skill set, it's a different way of talking. I think it makes a lot of sense.
Yeah.
And not because one's better than the other. It's because our skill sets, our personalities are different. As an ER doctor, I got to move on. I can't sit and talk and give you the time that you deserve. We saw that also with end of life care, right? An ER doctor, have a short conversation. If I have a palliative care doctor, they'll sit with you for an hour and talk about issues that are very important, but we don't have time for.
Exactly.
So I think that's great. What I do, again, we do MAT in the emergency department. I'll say a lot of people want Suboxone, but they want it just for help withdrawal. And I'll say, don't use it. The mistake I see is people using it just for withdrawal. And I'll say, it takes 6 months, a year, some people a lifetime to help with craving, right? To make sure you don't use, and that's one way that you know that you need to keep using it is if you have the craving, if it's talking to you and you really want it, that means better to stay on buprenorphine. And depending on how long they've been using, I'd say then, you need to be on it for 6 months, a year, or even more. And if you want to stop, just, try it. But if you're having cravings, go back to bupe instead of to fentanyl.
Right.
Well, I think that's true with this, this younger population, late teens, early 20s, because that brain development, they introduced drugs before that brain had fully developed. And so, I talk to people about that in our experience. My son was 20 at the time. So, do I think he would have had the same success without it? Probably not,
Or maybe he won't need it as longer. I mean, my patients have been like, they've been using for 20 years. Okay, you've been using for 20 years. Your brain is not going to go back to normal in a year.
Yeah.
Probably, right? If it took you 20 years to get to this point, it's not going to be, 2 weeks for sure. Or even 6 more years, right?
Hardwiring going on there at this point. Yes.
So, and it's better to use that. And the other analogy I use is with diabetes. Some people can just stop eating cake and not have their sugars go up. Some people need pills. Some people need an insulin pump for the rest of their lives. So everybody's different. Like you said, not one size fits all. You see a lot. Both of you have worked with the intersection of substance use disorder and mental health. How are you seeing that play out in this project and in your work in general?
They're so connected, aren't they? They're just really so connected.
We try to make it separate, but it really isn't.
It's not. It's, so I have a study from way back that tried to look at, which came first, the mental health. And because one of the things we say is that we use drugs to treat, to self-medicate our mental health problems. And I think to a large extent that is true. But as far as what initiates this, it's often, particularly in adolescence, that you see the substance use, the experimentation with substance use happening initially, which then starts to affect the mental health piece. And then you end up in this cycle of, well, then I need more to make myself feel less bad about what I just did, or whatever that is. But you then see this cycle, and it is self-medicating. It becomes self-medicating. But I just think that MAT, you need to address the drug dependency there in order to get to start on the mental health and to start addressing the mental health components that are feeding this or leading you to do this. And so as much as I feel like we need to get them on Suboxone first, deal with the cravings, deal with the addiction piece of this so that they can start to address the mental health components. And, if they never deal with the mental health components and they stay on Suboxone, that's fine. They're not using anymore. They're not at risk of dying. But if you don't address the mental health, you still have, it's manifesting some other way. That's manifested some other way. And whether it's in your relationships, your inability to hold a job, whatever. So I feel like we've got to, as a society, address the mental health disparities.
If I could add to that, one of the things I stress in the post-overdose response training with the EMS professionals is you have to treat the whole person. So really looking at SAMHSA's 8 dimensions of wellness, you've got to address those. So one of our forms actually assess that with these individuals. So looking at their housing, looking at finances, looking at trauma. I mean, you and I both know that trauma is a big issue in this population. So you've got to get them some trauma care. A lot of the MAT providers do some therapy along with the medication. But not everybody is ready yet. Some people just want the medication. And I feel like you have to meet people where they're at. If that's their first step and they're willing to do, and we can use it even as a harm reduction method to keep them alive, to move to those next steps. They have to start seeing somebody that does care enough to ask them about all these different areas of my life. But I think we have to treat the whole person, just past just the addiction and mental health.
Right. We see that mix also, and I don't know how much in North Carolina you have methamphetamines, but it's very rare for us to find someone with just an opiate use disorder. It's they also have methamphetamine disorder, alcohol use disorder, benzodiazepine use disorder. It's hard to find just that, and it's like we grab onto the opioid because I have a tool, I can fix this, but they still have other ones.
And absolutely, it has become so much more complex, hasn't it? And I think that's why you're seeing so many funding mechanisms coming out now to try and look at polysubstance use and overdose, because so many folks are combining the methamphetamine with the opioids, or the fentanyl. The fentanyl, of course, is in everything at this point. So that's, regardless of your drug of choice, this is, people don't even realize they're at risk of overdose because they're using the cocaine, as we have the example of the West Point cadets on spring break just a week or so ago. Fentanyl is in everything. And so, they're getting the opioid addiction, whether they intend to or not, it seems like. But how addressing the opioid piece then makes the methamphetamine or the other addictions or the alcohol, it's so complex, and I'm not sophisticated enough to know how to address all those pieces. That's not, I don't have that expertise, but I do know it's getting harder and harder.
The West Point cadets, as you mentioned, they were using cocaine and they didn't know it was laced with fentanyl, and ended up 6 of them overdosed, ended up on ventilators. So not pretty. They probably did not have an opiate use disorder or an addiction. They didn't need naloxone. They needed probably fentanyl testing strips to test their cocaine supply. So everything is different, but you're right. Fentanyl has been a game changer. It's in the entire drug supply. That's why I give free naloxone prescriptions on my website, because people it should frankly be over the counter.
It should be over the counter.
Since it's not over the counter, I am going to buck the system and give it free to people if they need it. It is very complex, as you said.
And I think that people just don't realize, it's shocking. I mean, it's clearly those cadets were certainly not, regular drug users, or they probably would have known that you don't risk this, without having some Narcan or something. But people don't realize.
Right. They were not users. They were cadets. They were not drug users. They were out to party.
Have some fun.
That's the point of fentanyl, is one mistake could be your last mistake, which is very sad. So we're talking about really an approach on harm reduction and treatment at one end for people who are heavy users. That's what your whole program, community paramedic and treatment is. And then I just kind of want to hear your opinion on prevention, preventing addiction in the first place. We're putting so many resources, and they're important. It's to people who have an addiction to treat them. I see that working at a trauma center. It's like giving blood to somebody who's got a trauma and bleeding to death. That's important. But wouldn't it be nice if we could prevent addiction in the first place, and that less people would need blood? And for that, I bring the conversation to what people may be uncomfortable with, but I cannot talk about prevention of fentanyl if we don't talk about prevention of marijuana, because I haven't met a single person who, and correct me if I'm wrong, but I haven't met a person who ended up overdosing on fentanyl that didn't sometime when they're 12, 13 years old even. 10 was my patient yesterday who started at marijuana. And what do you guys think?
I've done this for over 26 years, and I see the same thing. I mean, I've asked, that history, and
is that what you're finding too?
That most every one of them started with smoking marijuana, and there's nothing to that, and
Or
but-
underage drinking and then marijuana. It's funny in my time in New Mexico, so I started working there in 2007, and we would gather youth data and, attitudes about and perception of risk of harm from cigarette smoking and, alcohol, underage drinking, and marijuana use, and et cetera, et cetera. And you saw this beautiful sort of contrast between tobacco, cigarette smoking, where we've succeeded in teaching kids that smoking cigarettes, at least vaping was not around really at that point, or not big on the scene, where, their perception of the harm of smoking cigarettes just increased beautifully over the years, with all the messaging that was going out, and the, I was amazed. I'm like, wow, for once, they're finally getting the message. And then New Mexico, of course, has medical marijuana, and has just, I don't know if it's, I guess legalization of recreational marijuana has just gone into effect as well in the past year or so. But medical marijuana, you just saw this decrease again of the perception of harm of using marijuana, just in contrast to the tobacco. And I just kept thinking, and then Colorado became, which was just north of New Mexico, legalized recreational marijuana, and we started again seeing the underage, the high school students going across the border, getting the gummies, doing stuff like that, and just bringing it into the schools. And so and as a teacher, you can't tell if somebody's eating gummies or gummies with marijuana or brownies or any of those things. The edibles were a great way to bring it into school and share it. And you would only find out if people had too many. You would only figure out what was going on. I don't know how I feel about it. I'm so mixed. I don't feel that youth should be using it by any means. I feel like we need to recognize that it is affecting the developing brain in all the ways that we don't want it to be developing, in creating neural pathways that we don't want to be created. And it's something that is a slippery slope. And I don't feel like, at the same time, I don't feel like I want to criminalize it, if that makes sense. So I'm not necessarily for legalizing it, but I don't want to criminalize it.
And that's what the industry says. My point on it is, I don't want to criminalize. It's not even an issue of legalization. I'm sure it's about informed. It's about informed consumers. So we know if you're using alcohol, it's a problem. We know tobacco is a problem. We know heroin, cocaine is probably not good for you. But we're getting a completely different message on cannabis, and that's why it makes it different. That's why I'm empowering you to talk and say what I know that you feel. It's okay to say it out loud.
Absolutely. And it's certainly not good for young people by any means. And we need to regulate it the way we regulate, I think we're trying, but the message that's coming across, you're absolutely right, is that, it's harmless. No one's ever overdosed on marijuana. I see marijuana poisoning every single day, and they do overdose every day. And it's more like nobody dies of a puff of cigarette. You're right. But what a cigarette does to your lung, THC is doing to your brain. Right.
Tara, what about you? And
I agree, and I think so many parents even discount it because we did that back in the day. I hear that. And I don't think they understand too how cannabis has changed, and that it does now get laced sometimes, things like fentanyl. So I feel like it's a slippery slope too, that it starts that neural pathway. And for so many people I've worked with over the years, that has been their initial drug they started with.
Yeah. And then they move on from there. This has been very enlightening. I really admire you. You were able to take a whole community and bring such resources to a rural area in the field to people who need it. After a 911 call, bringing all that to an individual, that's amazing. I think that shows how much you care about the people and how it make a difference. And then you brought science and data to that aspect. I don't know if that's like the solution for the entire country, but the way that you're able to think out of the box and bring solutions, test them out, tweak them even, and see what would work, maybe not in this setting, but in another one. I think that's absolutely amazing. And do you have any advice for Crystal?
Remind me of Crystal's
Crystal is a nurse, an emergency department nurse, who's wondering about, paramedics who are can get involved in the treatment of MAT, or really, why don't you give any parental advice that you have here?
I mean, my piece with that, with Crystal stuff, is really building those partnerships together. How many times does the ED really work with EMS other than dropping off a patient, but to really build solutions together? That for us, when I did that with my task force, that was huge. Our ED actually had those peer support specialists in the ED to start that conversation with people. I think we've got to branch out. We saw with COVID, EMS started working with public health. We should already be doing that around the addiction world, working with public health, DSS. I mean, here in our area, a bunch of the parents that have kids in custody at DSS is because of substance use. So over half. So, the partnerships is what I really express, that's so important, and bringing EMS to the table. EMS usually doesn't get brought to the table.
Tara, in fact, your task force that you created in Forsyth County really, I think was a great example of, and you initiated, so EMS initiated this, but you brought the addiction psychiatrists, you brought the treatment providers, you brought the, even the faith-based community and the police and everybody together to say, hey, we've all got to be talking to each other. The fact that you as a community paramedic were able to talk to a patient and know what are the options for treatment. You're a pregnant mom, or you're a mom with children. What are the options for you that are going to look different from somebody who wants inpatient and doesn't have to go to a job on a regular basis? That I think is critical, that ideally, if there are paramedics who know what does the treatment community look like, what are the connections, how can you refer people to something that might work for them, I think is huge. I know that that's not a paramedic's job. It's a wonderful thing to have that connection and to have that knowledge, and to be able to work with a patient who says, I'm ready for treatment, but I got to work my job. I can't go to inpatient, or, I can't go to therapy at 11 o'clock in the morning because I work from 9 to 5. So here's another option. Here are some, and then of course, building up those options. Of course, so many of our rural communities don't have providers in place, and COVID made it
not
so
just
much
rural
harder.
communities.
Yeah,
Right?
That's true. But what else is out there? And
I think that's, I'm not the traditional paramedic. Having that background in mental health and substance use has served me well, for sure. And I think it's bringing the behavioral health providers to the table too. Those psych nurses, like you were talking about, they do have a wealth of knowledge. And, I was fortunate to work in the hospital and in the community with some great psych nurses, some great psychiatrists that helped build that knowledge base for me, and really we treated the whole person. I went grocery shopping with patients. I helped find them housing. I saw all the struggles they went to related to mental health and substance use. Most of them were dually diagnosed. And so they are so interconnected, right? And I know that background helps me with these creative thinking ideas, because, we got to help them fight the barriers, whether that's childcare, whether that's their job. MAT providers put a lot of restrictions on, you've got to do it this way to come to a program.
Right. I think that's great advice. Thank you both. I say we take all that COVID contact tracing money and put it into contact tracing for overdoses and doing these kind of programs that you're doing. I think that's what we need to do. We actually have more deaths from fentanyl, age 18 to 45, in the entire United States for any reason, more fentanyl deaths in that group than COVID, suicides, or anything. So I think it definitely needs the attention and the creativity and the community partnerships that you two have demonstrated. Crystal Garibaldi, thank you for your question. I miss you. I miss your amazing spirit in our emergency department. I bless you with health and happiness for you and your entire family. And Martha Waller, Tara Tucker, thank you for your innovations, tapping into the many skills our paramedics have in helping this unique and important patient population.
Thank you.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support from our sponsor. A sincere and warm thank you to FAF, Families Against Fentanyl. Visit familiesagainstfentanyl.org and sign the petition to declare illegal fentanyl a weapon of mass destruction. Make drug dealers think twice and 3 times before peddling killer drugs. Our producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more high truths.